Hello everyone, I am Dr. Deepika Agrawal, Professor and Head Department of Community Medicine, Santosh Medical College. Today we will be talking about COVID-19. As you all know, we have been suffering from COVID-19 since 2020. So this lecture is about the epidemiology of COVID-19, how to recognize the clinical features of the disease, manage a patient of mild and moderate COVID-19 disease, and the prevention and control strategies adopted at the level of the community. So to start with, let me give you an introduction of the COVID-19. See, coronaviruses are a group of RNA virus that cause respiratory infections, which are typically common cold. But sometimes it may lead to severe forms of disease like SARS and MERS, which are fatal. The first suspected case of virus, that is COVID-19, were reported on 31st December 2019 from Wuhan, China. After that, we all know that this virus spread to all the countries in the vicinity all over the world, and WHO had to declare this as a global pandemic in March 2020. So this is the situational analysis you can see here as of now. This graph sums up the number of cases in WHO regions, different WHO regions, and the global deaths that have occurred due to the COVID-19 pandemic as of 23rd January 2020. So here you can see that this is the graph, the upper graph that shows the number of deaths. Here, this is the number of deaths, and this side we have the number of cases and the days, the dates and the days. So you can see here that it has peaked in between. See, it peaked in November, then in November 2020, then it peaked in April, May 2021, and now in January 2022, the cases have again peaked. So this is the situational analysis of the global pandemic of COVID-19 throughout the WHO regions. So you can see here that there have been multiple peaks over the last 2 years. Now again, this is the number wise, in numbers, this is the analysis of the different regions of the world with the new cases, the cumulative cases, and the deaths that have occurred due to the pandemic till 23rd January 2022. Now this is a very interesting slide in which it is seen, you can see, you can relate to it, that every 100 years a pandemic has been occurring globally. You can see in 1720 it was plague, in 1820 it was cholera outbreak, in 1920 it was Spanish flu, and in 2020 this COVID-19 pandemic break has occurred. So this is a theory that every 100 years a pandemic happens. So this actually correlates with the theory, the timing of the pandemic. Now, before I go ahead with the COVID-19 pandemic and talk in depth about it, let me tell you a very interesting term, that is the public health emergency of international concern. Now, what is meant by this term and who has given this term? Now, WHO, that is the World Health Organization, that has given this term. You know, it has coined this term, the public health emergency of international concern. And how has the WHO defined it? It has defined it as an extraordinary event that constitutes a public health risk that might spread to other countries and also require a coordinated and immediate international response. Now, this public health emergency of international concern is not just a term. It's an incident which requires global effort from all the countries. Okay, so now who actually determines which disease is the public health emergency of international concern. Who is that agency or who is that body which determines it? So here you can see that the Director General of the WHO along with the International Health Regulations Emergency Committee, okay, both of these together, they determine that which disease should be labeled as the public health emergency of international concern. So here the international experts on disease control, virology, vaccine development or infectious disease epidemiology, as well as one expert nominated by the country where the virus has started. So these make up the committee of the International Health Regulations Emergency Committee. Okay, and these people together with the Director General of the WHO, they determine which disease should be labeled as the public health emergency of international concern. So in the past, the different viruses that have been labeled as the PHEIC, they are the swine flu that happened in 2009, polio that happened in 2014, then Ebola, which was the virus that affected the West African region in 2014, Zika virus and Ebola virus of the Democratic Republic of the Congo. So all these viruses outbreaks have been declared as public health emergency of international concern in the past, and now it is the COVID-19 pandemic that has been declared as PHEIC. Now coming to the traditional epidemiological triad. Now you all know what are the 3 or 4 constituents of the epidemiological triad. That is the agent, host, environment intertwined with time. So here the agent is the coronavirus, the host are the human beings and the environment, that is our immediate environment, which could be physical or biological. And all these factors, when they come together in time, they can lead to the development of disease. So this is the epidemiological triad. Now coming back to the agent factors. Now you see here that coronavirus, see here, this is the Coronaviridae family. In this, it comprises of a helical enveloped single-stranded RNA virus, right? There are other families of the RNA viruses also which are related to Coronaviridae like Flaviviridae, Togaviridae, Retroviridae, Picornaviridae, Calliciviridae. So these are different RNA viruses which are single-stranded, and Coronaviridae is just one family out of all these, and the coronavirus of this COVID-19 pandemic, that belongs to the Coronaviridae family. Now what is the peculiarity of this coronavirus? As you can see in the picture here, this coronavirus are named for their crown-like spikes which are present on the surfaces. These are the spikes you can see here which are present on the surface of the coronavirus. And there are 4 main subgroups of coronavirus called as alpha, beta, gamma and delta, which have been recognized till now. And the human coronavirus, it's not that the coronavirus is something new that was recognized in 2019 only. It was recognized or first identified in the mid-1960s. But at that time, that coronavirus was not so lethal. It did not spread in such a huge way. The 7 coronaviruses that have infected people in the past are the alpha coronavirus, that is 229E, the beta coronavirus, that is OC43, the beta coronavirus HKU1, the alpha coronavirus NL63, the MERS coronavirus that caused the Middle East respiratory syndrome. It was first reported from Saudi Arabia in 2014. And the SARS-CoV beta coronavirus, which caused the severe acute respiratory syndrome. It was first recognized in China in November 2002. So this coronavirus, it dates back to mid 1960s, and there have been development of different coronaviruses, and they have affected the world population in general, with one form or the other form of the disease. And now in 2019, this has been named as the novel coronavirus. Now, what are the epidemiological characteristics of this coronavirus? See, initially the cases were exposed to the South China seafood market in Wuhan, and some of the cases they showed family clustering. So it was thought that this disease had spread from the animals in the seafood market. But later on, human to human and the medical staff infection also occurred, and it led to community transmission as well. We have seen community transmission during the first wave as well as during the second wave in 2020 and 2021. So the new coronavirus is deadly, and the fatality rate is high with some variants, but its high risk may be lower than that of the SARS. Now, severe acute respiratory distress syndrome causing coronavirus was more lethal than this novel coronavirus, and the fatality rate was quite high in SARS as compared to this novel coronavirus. But we have seen high fatalities during the peak waves, during the peak time by this novel coronavirus as well. So we have to be careful with this. So the mode of spread of this COVID-19 or the novel coronavirus has, as our understanding grew during the pandemic, the mode of spread has been identified as it could be the person-to-person transmission that may have occurred due to the direct contact with the secretions of the patient, or it could be the respiratory droplets that are produced when an infected person coughs or sneezes, which could be airborne. Then it could be spread through the healthcare workers who have carried the patients or who have been, involved in the care of the patients. And some people also say, or some researchers have also found a route of transmission to be the fecal route as well, but that is still debatable. It has not been conclusively found that fecal route is another mode of transmission. Now, talking about the risk factors first of all could be a recent travel to the places of the outbreak. If somebody has traveled to a country where the outbreak is currently active, then he may be at risk of getting the infection. Then close contact with people who are diagnosed with the disease, close contact with anyone who has visited the area of the outbreak, and that is why you must have heard the term quarantine. Okay, so that is where quarantine comes in, plays a role. Then contact with secretions from an infected person. So these are the different risk factors that have been incriminated in the spread of or getting the infection of novel coronavirus. Now, talking about the clinical presentation of a case of COVID-19. Now, this, first of all, it could be asymptomatic. The symptoms may be so mild that the patient fails to notice those symptoms. Otherwise, the symptoms may be mild like fever, cough, dyspnea, myalgia, fatigue, or upper respiratory tract signs and symptoms like rhinorrhea, sneezing. So these could be signs of mild diseases. Apart from these usual signs, there may be some less common symptoms as well, like headache, hemoptysis, diarrhea, vomiting. These have occurred in the patients of COVID-19, but to a lesser extent. Apart from these symptoms, there are other symptoms like anosmia, that is loss of sense of smell, loss of sense of taste. So almost 30% of the patients have also encountered these two things apart from the usual fever, cough and dyspnea. Now, what are the appropriate specimens for laboratory diagnosis? Now, laboratory diagnosis can be made, or the diagnosis can be confirmed with the help of blood cultures, or it could be by the RT-PCR. Okay, so these are for RT-PCR, the specimen, the ideal specimen are both the upper as well as the lower respiratory tract secretions. WHO recommends that the lower respiratory specimens such as sputum, endotracheal aspirate or bronchoalveolar lavage should be ideally collected for making a diagnosis of COVID-19. But if suppose the lower respiratory tract infection or lower respiratory tract specimen are not available, the patient is not able to give the lower respiratory tract specimen, then the specimen can be collected from the nasopharyngeal secretions or the oropharyngeal swabs as well. And these can be later tested by RT-PCR to make a diagnosis of COVID-19. Apart from these, there are other helpful diagnostic methods like chest imaging, which can shed some light on the invasiveness or the severity of the infection. For example, in the early stage, multiple small plaques and interstitial changes, they appear, which later on change to the ground glass shadows or infiltrations into both the lungs if the lower respiratory tract is involved. And in severe cases, we can see a consolidated lung on chest imaging. This could appear as a white lung, and even we can see the pleural effusion occurring in the lung fields. Now this is a referral form which is used in the hospitals for referring the patients of COVID-19 to a higher referral facility. Now before we go any further, let me tell you, since it was a pandemic and the whole community was getting involved, it was essential to define the cases, who is to be called a case of COVID-19 and whom to suspect and then whom to refer to the hospital. So the health ministry that coined these definitions, and these definitions were then made available to all the healthcare workers who were working in the field to suspect and catch the cases of COVID-19 early on to control the spread of the disease in the community. Now, as per the definition, a suspect case is a case with severe acute respiratory infection like fever, cough, and requiring admission to hospital, and with no other etiology, no other cause of this severe acute respiratory infection, and at least one of the following: either a history of travel to or residence in the city of Wuhan, Hubei province, China in the 14 days prior to symptom onset. Now here, this definition or this particular thing came into force during the early days of the pandemic, when it was confined to the Wuhan city only. So at that time, this definition was good for that. But later on, another component was added, which could be a history of travel to or residence in the city of outbreak of COVID-19. Okay, so it can be read like that. Or a patient is a healthcare worker who has been working in an environment where severe acute respiratory infections of unknown etiology are being cared for. So, who is a suspect case? A suspect case is the one who is suffering from severe acute respiratory infection for which no other etiology has been found, along with either a history of travel or residence in an outbreak related area, or a healthcare worker who is working in such a facility which is caring for the COVID-19 patients. Okay, so that case is a suspect case of, or a second definition for a suspect case is patients with any acute respiratory illness and at least one of the following: a close contact with a confirmed or probable case of 2019 novel coronavirus in the 14 days prior to the onset of the illness, or visiting or working in a live animal market in Wuhan, Hubei province, China prior to the onset of symptoms, or a person who has worked or attended a healthcare facility in the 14 days prior to onset of symptoms where patients with hospital associated 2019 novel coronavirus infections have been reported. So it could be severe respiratory illness without any etiology but with a history of travel or working in a healthcare setting, or it could be any acute respiratory illness with any one of these, that is the close contact with a confirmed or probable case, working in a live market, or attending or working in a healthcare facility. So all these cases fulfill the definition of a suspect case. Now coming to two other definitions, that is the probable case and the confirmed case. Now whom to treat as a probable case? A probable case is a suspect case for whom testing of 2019 novel coronavirus is inconclusive, or for whom the testing was positive on a pan-coronavirus assay. So that is a probable case. And a confirmed case is a person with lab confirmation of 2019 novel coronavirus infection, irrespective of his signs or symptoms. Now, it might be possible that by the time report comes, the signs and symptoms have subsided. But even then, we have to be very, very careful as that patient might still be able to infect others through whatever secretions may be coming out from him. Now, what are the different clinical syndromes that are associated with this COVID-19 disease? Now, they may be an uncomplicated illness, which can just be an upper respiratory tract infection, and this might be having some non-specific symptoms like fever, cough, sore throat, nasal congestion, headache, or malaise. Very non-specific symptoms. Or there could be a picture of mild pneumonia in which the patients with pneumonia would be showing the signs of pneumonia, like they would be having fever, a little more severe cough, there may be chest indrawing present, or there may be difficulty in breathing. Okay, but it may progress to severe pneumonia, in which the respiratory rate may be found to be more than 30 per minute. There may be severe respiratory distress with SpO2 dipping to less than 90% on room air. So that is a case of severe pneumonia and needs hospitalization. And then the most severe form is the ARDS, that is the acute respiratory distress syndrome. Now this could be very, very fatal if not treated early on, if not recognized early on. Chest imaging will show bilateral opacities in ARDS, and respiratory failure can be seen, which could be accompanied by cardiac failure or fluid overload. So ARDS is a highly fatal condition and need prompt hospitalization and prompt treatment. Then apart from that, there could be signs of sepsis as well in the patient, which can be seen as organ dysfunction, like he could be in an altered sensorium. There may be difficult or fast breathing, low oxygen saturation, reduced urine output, tachycardia, weak pulse, cold extremities or hypotension. And the laboratory evidence would show coagulopathy, thrombocytopenia, acidosis, high lactate or hyperbilirubinemia. So if these conditions are present, it shows that sepsis has developed in the patient and he needs continuous monitoring and supervised treatment. Then the another condition that can develop followed by sepsis is septic shock, which actually means persistent hypotension despite volume resuscitation, and it requires vasopressors to maintain a mean arterial pressure of more than 65 millimeters of mercury and a serum lactate of more than 2 millimoles per liter. So these are some of the symptoms, some of the signs, some of the clinical syndromes that are associated with COVID-19. So you can see the spectrum that ranges from very mild disease to very severe disease, which may become fatal later on. Now, what can be done or what should be done in such cases? Early supportive therapy and monitoring is the key. For those cases in which the SpO2 has dipped to less than 90% at room air, supplemental oxygen therapy should be initiated, and it should be initiated with 5 liters per minute to reach a target SpO2 of more than 90% in non-pregnant cases and more than 92 to 95% in pregnant cases. We use conservative fluid management when there is no evidence of shock. So if it is just pneumonia, then we use conservative fluid management. Then we give empirical antimicrobials to treat all the likely pathogens that could be responsible for the development of sepsis. So if a patient has landed into sepsis, then within 1 hour of the development of sepsis, that is as soon as possible, antimicrobial therapy should be started to cover the likely pathogens. And this empiric therapy should be de-escalated. That means it should be brought down slowly on the basis of microbiology results and clinical judgment of the treating doctor. Do not routinely give systemic corticosteroids. Closely monitor the patients with severe acute respiratory infections for signs of clinical deterioration such as ARDS, sepsis or respiratory failure. Along with all these things, we also have to manage the comorbidities. Now, we have already covered the epidemiology related to agent factors, the host factors, and the environment or the mode of transmission, the clinical features, and the broad treatment guidelines of these cases. Now, coming to the prevention and control strategies of COVID-19 pandemic that have been adopted during the last 2 years. First is early recognition and source control. See, any pandemic can be controlled or can be stopped by community efforts, by vigorous prevention and control strategies. if we don't apply these strategies timely, then any pandemic or epidemic that may wreak havoc on the community and may lead to a very high death toll. The reason why this pandemic has been brought under control is the appropriate and timely application of these prevention and control strategies. So what did we do in these strategies? The first one was early recognition of the case and source control. So all the healthcare workers, they were encouraged to have a high level of clinical suspicion. So if anybody presented with the signs and symptoms of respiratory infections, the upper respiratory infections, then he should be treated with a very high level of suspicion and should be treated as a case of coronavirus. So all the healthcare workers, the staff should take adequate personal protection measures to prevent the infection from developing, from catching that infection in them. Then awareness in the public areas, reminding the symptomatic patients to alert the healthcare workers. That means that in the community, if a person experiences signs and symptoms of respiratory infection, he must contact the healthcare worker present in his vicinity for appropriate advice and treatment. Promotion of respiratory hygiene. This was very, very important, and that is why we promoted the wearing of masks so that the respiratory droplets could be minimized in the environment. Then suspected cases should be placed in an area separate from that of the patients. So in a healthcare facility also there was delineation, demarcation between the diagnosed patients who were being treated for COVID-19 and the suspected patients whose reports were awaited, whose confirmation was awaited. So both of these were segregated. They were not allowed to mix. Then another key intervention was standard precautions for all the patients. Now what did that include? It included the hand and respiratory hygiene, that is wearing of medical mask to the suspected patients, cover nose and mouth during coughing with tissue or flexed elbow, perform hand hygiene after contact with respiratory secretions, that is either you wash your hands properly or you sanitize your hands. Then use of personal protective equipment, which was very essential for those healthcare workers and staff who took care of the COVID-19 patients in a healthcare facility. Prevention of needle stick or sharps injury. Safe waste management. Now this was very important. There were specific guidelines for managing the COVID-19 waste as it was deemed to be highly infectious. Then environmental cleaning and sterilization of patient care equipment and linen. So all these things, they came under the these biomedical waste management guidelines for COVID-19. There should be thorough cleaning with water and detergent of the areas where patients were putting up, and applying hospital level disinfectants like sodium hypochlorite, which is an effective and efficient procedure. Now these are some of the banners that the WHO made for educating the community. These have some catchy images with some catchy slogans on it, like this: reduce your risk of coronavirus infection by clean hands, Cover nose and mouth with the use of masks or tissues. Avoid close contact with anyone with cold or flu-like symptoms. Thoroughly cook meat and eggs, and don't come in contact with farm animals or sea animals. So these are some of the instructions that were devised by WHO. Other precautions that were to be taken or that are still being taken for suspected infections are as follows. All individuals, including family members, visitors, and healthcare workers, should apply contact and droplet precautions if you have come in contact with a suspected case. Place the patients in adequately ventilated single rooms, ideally. When single rooms aren't available, cohort patients suspected of novel coronavirus infection together in the same area. Place the patient beds at least 1 meter apart to minimize their exposure of droplet infection. Use medical mask, eye or facial protection, clean, non-sterile, long-sleeved, fluid-resistant gown and gloves. Use either a single-use disposable equipment or dedicated equipment for COVID-19 patients like stethoscopes and BP cuffs. They should not be used for other patients apart from COVID-19 ones. So there should be dedicated instruments for monitoring the COVID-19 patients. Avoid the movement of patients out of the room. Limit the number of healthcare workers, family members who come in contact with the suspected cases. Maintain a record of all persons entering the room as well as the healthcare staff. Now, choosing the correct mask is very, very important. Now, there are different type of masks that are available in the market. That is the paper mask, cotton mask, activated carbon mask, sponge mask, surgical mask, and N95 respirators. Now, you can see here that the paper mask, the cotton mask, the activated carbon mask, and the sponge masks, these are not the appropriate masks to be used by cases of COVID-19 or to be used by healthcare workers who are attending to the patients at a COVID-19 facility. Ideally, the correct masks for them are the surgical masks or the N95 respirators. Now, those staff or those people who are attending to the COVID-19 patients, where the droplet, the risk of droplet infections is deemed to be high. For example, those who are performing some procedures on the patients. Now, in such cases, N95 respirators should be worn by those staff. And otherwise, in other areas where the risk of droplet infections is not so high, simple surgical masks can be worn. Now, these are the details of the different types of masks here. So you can see here that N95 mask, it filters 95% of 0.3 micron particles and blocks the viruses. And it should be worn in suspected airborne diseases. Then there are disposable surgical masks. These have got 3 layers. And due to the presence of 3 layers, it becomes a better mask as compared to the simple cotton mask. Now, in relation to food also, the WHO had given some advisories, like use different chopping boards and knives for raw meat and cooked foods, because earlier it was thought to be spread through animals as well. Sick animals and animals that have died of diseases should not be eaten. Practice food safety even in areas experiencing outbreaks. Meat products can be safely consumed if these items have been cooked thoroughly and properly handled during food preparation. So all aseptic uh, caution has been taken, and we must wash our hands before handling raw and cooked food. So these are some of the food safety related advisories that were given by WHO at the start of the pandemic. Then another advisory had come up again to sensitize the people what to do and what not to do in case of COVID-19. Now these are the advisories that have come from time to time. Now, since hand washing and hand sanitization has been the single most effective method of prevention of the infection, it is essential that each one of us knows how to wash our hands thoroughly. So these are the 6 steps of hand washing that have been enumerated here. You can see how we have to go step by step to make our hands infection free. Not just COVID-19, all infections which may be spread through fingers, which may be spread through the secretions, that can be stopped if we maintain hand hygiene appropriately. Now, risk communication and community engagement is one of the most important and effective interventions in the public health response that has been uh, instrumental in controlling the epidemics. Now, this RCCE helps in preventing information demic. Now, please remember, what do we mean by information demic? It is an excessive amount of information about a problem, which makes it difficult to identify a solution. Now, in case of COVID-19 pandemic, you all must agree that there was so much of information that was being displayed everywhere on the social media, on the internet, on the different sites of health ministries, in print media. Okay, so there was such a huge form of information, but in that sea of information we were lost for solutions, and this RCCE that actually prevents us from getting lost in that huge information. And how is it done? It's simply done by educating the people about early recognition of the signs and symptoms, what to do and what not to do, and when to approach the healthcare worker. That's all. So please remember, at the end of this lecture, I would simply want to emphasize on Wuhan. That is, W stands for wash hands, U for use mask properly, H for having your temperature checked regularly, A means avoid large crowds or crowded places, and N, never to touch your face with unclean hands. So if you remember Wuhan and if you remember these things, you have a very high chance of protecting yourself against the infection. So this is just a summary of the different variants or different forms of the viruses which have evolved in the last 2 years and have caused different waves of the epidemic. Now, these are the 4 or 5 types of viruses that we have come across, that is the alpha virus, beta virus, gamma virus, delta virus, and the Omicron virus. These are the 5 different types of COVID-19 viruses which have led to the outbreaks again and again in the whole world. At present, we are dealing with the Omicron virus, which has high transmissibility but a reduced risk of hospitalization and severe cases. However, there is increased risk of reinfection, and the RT-PCR continues to be the most dependable diagnostic test for detecting the Omicron variant of novel coronavirus. And that is all in this lecture today. Hope you will remember the key guidelines of the lecture and will perform the hand and respiratory etiquettes. Thank you.